Let me go ahead and introduce our next presenter here. Our next perspectives here are going to shift a little bit more, and we're going to talk about the receiving end of transitions and what that can be like. So to kick things off for this next couple of segments, I want to introduce Hannah Studer this morning. Hannah is a licensed clinical social worker. She's currently working in organizational leadership with the nonprofit sector as deputy director of the organization Bridges to Change. Hannah spent the last 10 years of her career working with reentry populations, including prison diversion, prison reentry, drug court, probation, parole, and with populations at risk of incarceration. She began her career in 2014 working in prison reentry services as a co-occurring therapist and moved into organizational leadership as one way to change and challenge some of the structural racism within the behavioral health and nonprofit sectors. I suspect Hannah's got a lot of good stories and strong perspective that we're going to get today. So really excited to be able to welcome her to our program. So enough of me. Hannah, please, why don't you go ahead and take it from here? Thank you.
Thanks so much, Paul, and hello, good morning, everyone. I am really excited to be here and to share about this really, really important population. And I've been engaging, as Paul shared, with folks in and out of jail for the last 10 years. And part of what I'm going to be sharing today is peer support and the significance of peer support in the receiving end of jail transitions. And I could not do the work that I do without peers. And I've had the really unique opportunity in my social work and leadership career to never not work with peers. So I've never not had peers as a part of the teams that I'm working with. And that's very uncommon. And I know that. And I know that that is a humongous privilege and benefit. So I wanted to start this presentation and discussion about who is in jail. And who is in jail are valued community members. These are talented, caring, resilient, determined individuals. These are families, loved ones, parents, coaches, teachers, mentors, and leaders, and people who have experienced a wide range of system barriers. These are folks who continue to navigate an array of obstacles every day, yet show up authentically. And these are people who will and do provide leadership and mentorship to others. So I want to center that in our discussion today, and really hope to hear from you in the chat how you're not only experiencing working with folks in and out of jail, but also how you're going to center the knowledge that these are valued community members. So when we start to think about jail to community transition, we had Myque talk about really amazing things that are happening inside the jail. We had Melanie talk about really amazing ways that the jails are transitioning folks. But what does that mean when we get into the community? So the majority of folks, as we've heard today, in jail will return to the community. So we already know that. We know that the majority of people, over 90% of people, will return to the community. So these are valued community members, and we need to center their needs. And who is a part of that transition team? Well, we all are on this call. All of us are part of that transition team. And that transition needs to take a lot of intentionality. So oftentimes we'll see, as Melanie shared, really sudden releases. So we'll see folks release from jail at early hours of the morning or even later into the evening where providers are closed or unavailable. Sometimes with sudden releases, providers don't have the ability to do a sudden intake. Maybe the person was released a day before, their intake is scheduled the next day. So that's going to take a lot of care and coordination. Sometimes people immediately release to shelters. So they will release to shelters. They will also release to homelessness. And the impacts to that are, ongoing substance use. Cassi shared the significant risks 90 days after that release. This is one of the highest rates of overdose potential in our community. Oftentimes without a release plan, people return to people, places, and things that they're familiar with, which may not be part of their goals or part of how they want to make change in their lives. And then there's sometimes limited social service connection. So we have to, again, be very intentional with how we are releasing, when we're releasing, knowing that oftentimes at the community end, we cannot control any of that release plan. And there may be limited access to public transportation or any transportation post-release. I'll share a story later in my presentation, but I've had a lot of folks just simply walk to their provider's office from jail because they don't have a bus ticket, they don't have a cab all the time. And so I think really centering and knowing that people are releasing under conditions that are very challenging is crucial to our work. And they may not have access to a phone, right? They may not be able to even communicate or contact people who could be safe for them. They often have limited places they can return to and limited places, maybe they can't return home, maybe they can't return to the shelter for various reasons. And so having that plan is really critical. And I want you to take a moment to share in the chat some jail to community transition needs and experiences you have seen. So I'd love to see in the chat, what have you seen as you're working with folks who are recently releasing from jail, or maybe you're the first person that they're engaging with after they've released. It can be really important as providers to have flexible hours and appointment window times. I know that's not always available to us, but if your person is releasing from jail and they're 15 to 20 minutes late, how can we get them in, right? They still showed up. How can we get them in? How can we see them today? I recently experienced an individual who was released from jail, thought he had housing. The housing provider was not prepared. They weren't aware of that referral. And so he felt set up for failure. That was his feeling. And so how do we support individuals where systems are not working for them for a variety of reasons? And that transition team all working together is a really important part of how we can support folks returning to the community. Now, let's talk about transitioning from jail or from incarceration and stigma. So we talked a little bit about stigma. Melanie shared a little bit about stigma, but it's so important to be mindful about how and when you're asking personal information, as stigma with this population is significant. So when we start to think about all of the questions we have to ask very personal questions, we have to ask very in-depth questions. It's important to understand and hold that stigma is present almost all the time, nearly through every single element on this slide. So one important area for us as providers to consider is to normalize in your language. So even if the person hasn't said it yet, it doesn't mean that it doesn't apply to them. So one area that I utilize with folks in and out of incarceration is I use a phrase where I say, I know for many people who experience jail or other incarceration, this can happen, blank can happen. Is that your experience? So you're normalizing that it's a typical experience as people are entering jail or incarceration. And we're also offering an opportunity for them to share their experience. So really think about the ways that you can normalize stigma, or you can normalize areas that may be stigmatizing. What questions, and please use the chat here, what questions do you have about addressing stigma with this population? I'd love to see in the chat things that you're thinking about, the ways that you're approaching difficult or really personal conversations in your work, or maybe you are afraid to ask this question. Maybe you don't know how to phrase the question. So put those in the chat. And always express empathy and support. That sounds really difficult, and I'm so glad you're here. Always expressing empathy and support. And continuing to ask, who do you get support from? Who do you want to get support from? How can they be present with us here in this appointment? Can you call them for your next appointment? Can they come with you? So always understand that even when support is offered, that person might not feel that that's their support. And so how do we allow them to lead that support interaction? And then continue to understand that asking questions that hold stigma can challenge rapport. So often and offer ample time to provide support and build and repair rapport as you're asking really difficult questions. And you may ask the same question every day. I know in my practice, I ask the same questions over and over and over again. So I don't feel embarrassed. I don't feel like they're difficult questions. But the person who's hearing that question or having that question asked to them may feel like it's a very difficult question for them. You may be the only person who has asked them that question. So really be mindful about what that means as you're asking difficult questions. And then take a moment in the chat to share some ways that you approach minimizing stigma in your practice. I'd love to see how we can share knowledge, our wealth of knowledge in this room, and also get some really great strategies for reducing stigma. Now, transition need and scope. So we've talked about this. Myque shared some really great kind of buckets of transition needs. Melanie shared some ways that jails are preparing and collaborating for transition. But what does this mean as we get into folks actually transitioning back to the community? So we know that there are housing needs, we know that there are medical needs, we know that there are behavioral health needs, family support needs, employment, social support. Folks may not be able to be in contact with their family. They may not be able to return to their housing program. So transition needs are vast and really expansive and often change once someone returns to the community. I wanted to share a story of an individual I had worked with a couple of years ago. So this person's name is D. We're going to use the initial D. And several years ago, D had an appointment with me. I was his therapist. He had frequent jail incarceration episodes, and he was about 15 minutes late for his appointment. Now, I was used to this and waited for him in the lobby. So he was late, I was waiting in the lobby. And when he arrived, he shared that he needed water because he had just walked 5 miles to his appointment. And in that 5 miles, it was raining and it was winter in Portland. He shared that his bus pass and belongings had been stolen while he was sleeping outside, and he couldn't call me because his phone was also stolen. So he came in for his appointment. I got him some water, an electrolyte drink, and a hot cup of soup, and we went into our therapy session room. And once in the room, I kind of scanned this person's person, right? I scanned kind of what was going on. And I noticed that his hands were red and white and swollen in various areas. And his fingernails were bluish. And he saw me looking at his hands and he said, "Yeah, I know, I have frostbite." And he said, I think my feet are also rotting. They're wet. They've been wet for days. And I know they smell. He had no rain protection, nowhere to sleep, and had no dry clothes for days. Now, luckily, there was a peer on site, and that peer was ready to engage with this particular person. So I stepped outside of that therapy room and was able to bring that peer in. That time, D had finished his soup and was trying to organize his backpack to understand the remaining belongings that he had. And our peer in that moment stepped into action. So the peer met with D and immediately built rapport in ways that I could not. He called D's probation officer and let her know where he was. He secured emergency housing for that night. He had a transition plan for the next day for longer-term supportive housing. He transported D to that emergency bed, located dry clothes, gave him some bus tickets, emergency food, and introduced him to the housing support staff. Now, D at that time was reluctant to go to urgent care and declined medical support that night. However, because D had this different relationship with the peer, he went to urgent care the following day and was able to receive medical intervention with a longer-term support plan. So we have to be able to be flexible with our approach. In that moment, I was flexible with my approach. I knew we weren't going to be doing therapy that day. I knew that that person needed a very different type of care that I couldn't provide. And so as providers, I really want to encourage us to think about how can we pivot? How can we be flexible with the folks who are coming to us? Now, take a moment to think about how you could have engaged a peer in your practice, a situation, and how it could have supported the person that you're working with or were working with. So share that in the chat, and we will hopefully talk about later in our Q&A portion how you could use a peer and how peers could shift maybe your practice and shift your approach. Now, when we talk about community transitions and community engagement, we also need to think about community and transition acuity. So oftentimes, wait times to care in the community can exacerbate symptoms and acuity. So if folks are waiting 7-8 months on the streets to get a bed, at a safe place, if they are waiting months or weeks for behavioral health appointment, if they're waiting months or weeks for a medical appointment, we know that the symptoms are going to increase. We know that that acuity is going to be more significant. And in the organization I work for, and over the last probably 5 years, we continue to see the SUD, mental health, and medical acuity so significant that housing and other more standardized services aren't able to meet the need. So it's important to understand that acuity and stabilization is taking longer and requiring more help and support than we've seen for many years. Now, coordinated efforts of SUD, mental health, peer, medical, and probation, that is some of the core team needed to reduce that acuity and support that transition. Coordinated care will require medical professionals to adjust their approach to meeting the needs. So as we talked about in the last slide, we have to adjust our approach. We have to pivot. And in what ways can we do that? In what ways can we bring in other providers to do some of that work that we can't? Now, hopefully you can use the chat function here to also talk about what changes you've seen or noticed in the community or within this population. So have you seen the acuity change and shift over time? What does that look like, and what are you noticing? Now, let's talk about the peer scope and peer support. So I cannot stress enough that peer providers and traditional health workers are the glue to helping jail transitions, but also engaging the system or network of care. They are really truly the glue to how we are navigating this very complex system with individuals who experience a significant amount of barriers. Peers, more than any other professional, understand the nuances and experiences of people impacted by the jail system. Peers have the ability and the training to build rapport by using their lived experience in ways that other providers can't. And we have to be mindful about consultation and peer expertise. So don't tokenize peers or offload care to a peer because you have limited time. Our peers are experts in system navigation and lived experience. They are valued members of this care team and should have a similar level of consultation and support opportunity as other team members. So how can we bring them to the table and really utilize their expertise in ways that make sense for our clients and our population? Hopefully you can use the chat here to think about how you can support peer scope and practice. So think about ways that you could consult a peer. How would you use a peer as a consultation provider? And then peer scope. I really like to continue to center what peers do and what peers don't do. So peers can do a lot of things. Peers are incredible members of our team. But think about and hold true to what peers do and don't do. So peers are experts in building relationships, system navigation, resource support, provider collaboration, skills, social skills and support. But what they don't do is diagnose mental health conditions. They don't provide clinical recommendation. They don't provide therapy services. They don't act as the primary crisis provider, although they are a part of that crisis team. And they don't provide recovery sponsorship to their clients. So just know that there are boundaries within what peers do and don't do. And then current workforce shifts have peers doing a lot of things outside their scope. So again, community acuity has increased and the call for peers has increased. And through that process, we need to be very mindful of how and when we're utilizing peer consultation and support. Think about how you want to engage peers in your practice. How could you recruit, train, hire peers to work in your practice, and what would that do differently for your practice? Now, as part of this transition team, certainly there are people and providers not listed on this screen, but this is just an example of core folks who are at the table who should be part of the transition team. So all of us are part of the team. We must understand the role and scope and engage peer providers as valued experts to consult with. Ask if they already have a peer. If you're working with someone, ask them if they already have a peer. The likelihood is that they do. And if they don't, how can we support them in accessing a peer or traditional health worker? Remember to take time to get to know the individual you're seeing. So if you are rushed in your day or you have back-to-back appointments, really think about how you're going to center rapport building in that appointment. Think about language that could be stigmatizing. Understand the impacts of stigma and the potential for stigmatizing topics in your assessment and treatment process. And then again, normalize and contextualize your understanding. So that example of, I know for some people transitioning from jail, they experience blank. Is that similar to your experience? Again, normalizing some of that potentially stigmatizing experience. And then think about how you can be an active member of the transition team, not a passive member, but an active member of that transition team. And remember, people transitioning from jail to the community are valued community members. 90% of people in jail will return to the community. So this is our community. Thank you for your time. I'm really excited for our next presenter and appreciate our opportunity here today.
Wow, Hannah, thank you. That was absolutely amazing. And for me, very emotional, I think, as well. Just incredible. Thank you for being so generous with sharing your work. It's truly, truly amazing. We've had great great luck getting these presenters to be so open for us here today, and being so willing to share their stories. I think you're going to find our next presenter is going to be very generous in that regard as well.